Hi and welcome back to our weekly COVID-19 update with Dr. Manfred, Director of University of Haifa's International Master's Program in Public Health, hosted by the American Society of the University of Haifa every Monday at 9 a.m. Eastern. For more information on the university's ongoing response and briefings around COVID-19 and to support the university during this time, please find a link included in this post. Thanks again, and turning over to you, Dr. Green.
Thank you very much, James. Okay, so we're coming back again. I'm very pleased to be back with you and just give you an update. Again, we're in this framework of the pandemic, which started in December, declared as a pandemic by WHO in March. And the case count since we last met, it's a week ago, is now gone up to nearly 3 million. And that's an increase of about 25%. But the deaths have nearly doubled. And remember that the deaths actually lag the case count. So in fact, it doesn't mean that the deaths are actually increasing more rapidly. It just means that there's a time lag of a couple of weeks from identifying a case to actually seeing possible fatalities. I actually was at a meeting yesterday or the day before yesterday with some professionals, cardiologists, and a couple of them said that they didn't think that COVID-19 was any different from influenza. And I was kind of surprised to hear that because I thought that it was clear to everybody, or at least to most. So what I'm going to do is actually give some hard facts and compare COVID-19 with influenza today. And then let's see where that takes us. So the similarities, that's true that in the early stages, most cases are asymptomatic and many of them remain asymptomatic. That's true for both COVID-19 and for influenza. And the early signs can be similar, the so-called influenza-like illness, and they're familiar to you, sore throat, sometimes a fever, a cough. So that's really the beginning. But then we come to the differences. And the differences, and I want to make it very clear because I hope that everyone understands this, that there are very marked differences between the two. Firstly, of course, they are totally different viruses. So the influenza and COVID-19 are caused by totally different viruses, different families, they're not related to each other. COVID-19 is caused by a virus that's closely related to that which caused SARS. And SARS, if you may remember, was a very serious disease. Fortunately, because it was so lethal, it had about a 10% mortality. It was easy, and almost all cases were symptomatic. It was easy to isolate cases. Unfortunately, a number of people lost their lives, but it actually died out and the virus disappeared because it was easy to basically contain it. COVID-19 has many more severe complications than influenza, and particularly the acute respiratory distress syndrome, which is one of the syndromes where, in fact, that can lead to death. And COVID-19 is much more likely to affect other organs. So it can affect the heart, it can affect the liver. It has, and now they talk that it may, and it causes the clotting system. So in fact, it has a much wider spectrum of effects than influenza. The difference in the behavior and the impact of the virus is also important. The average number of people that a COVID-19 patient infects is about 2.5 times higher than that for flu. It may be that that number is not exact, but we do know that it does infect more people, and we can see that in the way it spreads very rapidly. It's also more difficult to achieve herd immunity than for flu because of that. So the herd immunity, meaning the percentage of the population who should be immune in order to prevent further spread or reduce further spread, is a lot higher. Some reported at 60%, and we kind of don't know the exact number, but it's certainly somewhere in that region. And most cases of flu are self-limiting. There are deaths, and we'll talk about that. But for COVID-19, about 20% are severe. So in addition to the fact that there are deaths, a lot of people actually are severely ill. They need to be hospitalized, and some require ventilation. So why is COVID-19 generating so much more fear than influenza? Because influenza has been around basically pretty much for time immemorial. So we're used to influenza killing some people every year, and we'll look at that. That's kind of a strange thing to say, but in fact, this kind of almost numbs the population. It says, well, that's part of life. COVID-19 has the potential only to kill many more, particularly among the elderly. And in addition, COVID-19 is going to add an additional risk to influenza. So not only will we have influenza, we'll then have COVID-19. And we don't have a vaccine, which we do for influenza, and we don't have an effective treatment, and we have some reasonable treatments for influenza. So what are the questions, basically? The questions are what are the mortality rates from influenza? And we'll compare them with the potential mortality rates from COVID-19. Then what can we do about it and why? So the difference in mortality from influenza and COVID-19, generally based on modeling, and the same kind of modeling that we're doing with COVID-19, although we have maybe some more exact data at the moment for COVID-19. Influenza is estimated to kill between 400,000 and 500,000 people each year, maybe something like 30,000 in the United States or thereabouts, depending on the year. But let's say that that's a rough estimate. At this stage of the COVID-19 pandemic, already more than 200,000 have died. And you have to remember that we're at the beginning of the pandemic and we've introduced very restrictive measures. So with these restrictive measures and the fact that we're really pretty much at the beginning of the pandemic, we have already seen 200,000. So you saw that we've seen nearly half of what we would see in the world, basically, in a regular influenza season. And here's a graph which I'll explain. These are two graphs that have been taken from the Centers for Disease Control in the US. On the left, influenza, on the right, COVID-19. And these are what's called case-fatality rate. So what it means by age, so what it means is of the people who get sick, at least that we know of, what percentage die? So obviously the numbers may not be exact, but what I want you to do is to look basically at the relative difference. You can see that influenza, we get to about 1% over the age of 65, and it may be a little bit more or less. Let's not argue too much about that. But if you look at COVID-19, what we know about now, when you get to the elderly, it's at least 10 times and maybe more lethal in terms of the number of people who die or the percentage of people who die among the cases. And you can see there's a dramatic difference between the two. So again, a very marked difference. In developed countries, just to give you a picture, in developed countries, about 1 in 200 people die every year from anything. That's the mortality rate. That's the sort of thing, 8 per 1,000 in the United States, something like that. More than 50% are, of course, over the age of 80, because in the developed countries, we're getting to that as the life expectancy. But what can COVID-19 do? If 50% of the population become infected with COVID-19 in 1 year, and 1% of them die of the infection, that will double the total mortality for that year. So you can imagine that that actually is going to dramatically increase the mortality for that year. And let's just have a look at it. I think I just want to make clear, I'm saying it at 50% being infected and 1% dying. So just for example, in the United States, if we took 50% of the population, which are like 150 million, and you had 1% of them dying, then you'd get to something like 1.5 million people dying from COVID-19. We hope that's not going to happen. But what I'm saying is that that is a kind of potential without any intervention. And if you look at these graphs, these are the weekly percent deaths from pneumonia, influenza, and COVID-19 in the US, also taken from CDC and from the NCHS. And these are basically recording pneumonia, influenza, and COVID-19 mortality. And the red line is actually this year. The other lines are actually the averages that you see each year. What you see basically in 2018, when you look at that red line there, the red line is extended to 2018, you'll see there that that's the winter peak. Look what's happened basically now in this. You can see how that line has shot upwards. So in other words, we're now talking about the overall percentage of deaths due to pneumonia, influenza, and COVID-19 out of total death. So you can see that it's completely different from influenza. If it was just influenza, it would look pretty much like that little peak on the left side. And if you look at this in the UK, you can see here that these are absolute deaths, and these are also weekly deaths. following from January to now, and looking at the average, which is that gray line, which is maybe difficult to see, the normal rate. But you can see at the end there, this is the COVID-19 pandemic, and you can see how that's jumped up, and we're really seeing basically twice as many total deaths at this time, and that contribution has come from COVID-19. So what can we do? I've given you more or less the kind of pessimistic side. So let's have a look and see what we can do. Firstly, we need to buy time. The important reason why we want to buy time and slow down the epidemic is that helps us really to get organized, and that's already happening. And let's look at the different ways in which we're getting organized. First of all, we're getting organized by improving treatment. It may sound almost obvious, but the more we understand the disease, the better the treatment will be, even if it's not actual medication. But we get used to, the doctors, the physicians who are treating, understand better how to actually give good treatment to the patients, good, even supportive treatment. For example, there's much more experience now on what kind of ventilation to give. And in fact, there is even a discussion now and on the possibility that some of the people who have been put on ventilators may do better if they were given oxygen by another means. In other words, not through a mechanical ventilator, but other possibilities. And that seems to be, for some of the patients, a better option. So this is something that we're actually learning right now. And that looks like it's going to improve the so-called the case fatality rates. By the way, we're seeing that in Israel to some extent, of very desperately ill patients who are actually getting better and leaving the hospital. We can accumulate the experience in supportive care. So that's more general, not just the ventilation, because they're seeing more patients. It's easier now to understand how to treat these patients. Unfortunately, it's on the basis of experience with others who are less fortunate. But that's what happens as the pandemic progresses. There's still no agreed upon effective drug therapy, but we need large clinical trials, and they are underway. And it seems very likely that there will be better drugs that will be coming out. So we'll have a means of actually treating this. We need to develop vaccines, as we all know. Clinical trials have begun, but that's going to take time. These vaccine trials take a long time. You need the results of safety and efficacy, and then wide-scale production. So hopefully within 12 to 18 months, there will be something available. But again, I think that we have to be cautious about it and look at all the other things that we can do. One of the things that has large promise, but again, there are some issues about getting it in place, is to produce a passive vaccine. A passive vaccine is basically antibodies, which you take from previously infected people and produce immune globulin. I've already mentioned it before. It's been used for temporary preventing diseases such as hepatitis A. So what you do is you actually inject to the person the antibodies, and they are temporarily protected. And this could be a very promising solution for temporary protection. The one reason why I say that is it's quite possible that this coronavirus, this COVID-19 disease, is going to be a winter disease. In that sense, similar to influenza. If so, it may be possible at some stage, if we can get production of immunoglobulin to a level which we can have large quantities, then in fact, you may be able to give sensitive populations a dose, in other words, an injection at the beginning of the winter season, let's say November, and cover them until for 3 or 4 months. And that'll at least reduce that winter peak that we're worried about. Obviously, it's a very much speculative, because to produce the quantities that are required doesn't seem feasible at the moment. But it's one of the directions that I think will be investigated in depth. So we may be in a situation where, in fact, passive immunization will be given to a lot of people, either once a year or even twice a year. That could even be given twice. And you target elderly and those with underlying health conditions. And as I mentioned, it would include health workers and other essential workers. It may also produce some herd immunity, by the way, because these people then are at that period of time immune from the disease. So what is the future? Well, basically, we need to keep some preventive measures at a level which maintains the economy and slows the pandemic. We really have to develop a strategy for preventing both influenza and COVID-19 at the same time. So if COVID-19, as we suspect, will become a winter disease, we have to first make sure that influenza vaccine adherence increases dramatically. Children are still not vaccinated enough. So if we can eliminate or reduce, we won't eliminate, but reduce substantially the spread of influenza, and that can be done particularly by vaccinating children, we reduce dramatically the impact of influenza. And if we can retain some physical distancing in the winter, we'll affect both influenza and COVID-19. Well, Yogi Berra basically said the future ain't what it used to be. So that's where we are at the moment. Thanks very much.